Hey parents, how do you make smarter choices for your kids' college today? That's where Sally can help. With Sally, you can find scholarships, funding options, tools, and guidance all in one place. And if you need a loan, Sally has options for different families and different situations. College is only worth it if you do it right. So don't just help your kid go. Help them go smarter. Sally.com/GoParents.
Hey everyone, Chris here from MedPrepToGo, and welcome to another episode of our USMLE Step 1 Questions podcast. In this episode, I'll be reading 3 more anatomy questions from our online Qbank, and of course, you can read these questions and more at MedPrepToGo.com. And with that being said, let's get started with question 1, Anatomy 26. A 52-year-old man comes to the clinic because of an enlarging pigmented lesion on the lower anterior abdominal wall. Past medical history is significant for hypertension. On physical examination, there is an irregularly shaped pigmented lesion located 4 centimeters inferior to the umbilicus and 3 centimeters lateral to the midline. There is no palpable lymphadenopathy. Excisional biopsy shows malignant melanoma. The patient is scheduled for sentinel lymph node biopsy to evaluate early lymphatic spread. Which of the following lymph node groups is most likely to first receive lymphatic drainage from this lesion? Is it A, external iliac lymph nodes, B, internal iliac lymph nodes, C, para-aortic lymph nodes, D, superficial inguinal lymph nodes, or E, vertical deep inguinal lymph nodes? And the answer is D, superficial inguinal lymph nodes. The superficial lymphatics of the anterior abdominal wall are divided by the level of the umbilicus. Skin and superficial tissues inferior to the umbilicus drain primarily to the superficial inguinal lymph nodes, whereas those superior to the umbilicus drain towards the axillary lymph nodes. Because this melanoma is located on the lower anterior abdominal wall inferior to the umbilicus, the superficial inguinal nodes are the most likely first site of lymphatic drainage. This pattern is clinically important when selecting nodal basins for sentinel lymph node biopsy. Answer choice A, external iliac lymph nodes, is incorrect. External iliac lymph nodes receive drainage from deeper structures of the anterior abdominal wall and some pelvic organs. A superficial cutaneous lesion inferior to the umbilicus would usually drain first to the superficial inguinal nodes before reaching deeper iliac nodal groups. Answer choice B, internal iliac lymph nodes, is incorrect. Internal iliac lymph nodes receive lymphatic drainage from pelvic viscera, deep perineal structures, and gluteal regions. They are not the primary first draining nodes for a superficial melanoma of the lower anterior abdominal wall. Answer choice C, para-aortic lymph nodes, is incorrect. Para-aortic lymph nodes receive lymphatic drainage from structures such as the kidneys, testes, ovaries, and other organs derived from the posterior abdominal wall. They would not be the initial drainage site for a superficial skin lesion of the lower anterior abdominal wall. Answer choice E, vertical deep inguinal lymph nodes, is incorrect. Deep inguinal nodes receive lymphatic drainage from deep structures of the lower limb and from the glans penis or clitoris. Although lymphatic drainage may eventually pass from superficial inguinal nodes to deeper nodal groups, the first draining nodes for this superficial abdominal wall lesion are the superficial inguinal nodes. Key learning point. Superficial lymphatic drainage of the anterior abdominal wall travels to axillary nodes above the umbilicus into superficial inguinal nodes below the umbilicus. Question 2, Anatomy 27. A 68-year-old man comes to the clinic because of progressive right buttock and thigh pain when walking uphill for the past 2 months. He has hypertension, hyperlipidemia, type 2 diabetes mellitus, and a 50-pack per year smoking history. On physical examination, femoral pulse is diminished on the right, but distal pulses are faintly palpable. CT angiography shows chronic severe stenosis of the right external iliac artery proximal to the inguinal ligament, with enlarged collateral vessels around the posterior hip. Blood flow from the internal iliac system to the deep femoral system is most likely maintained through an anastomosis involving which of the following arteries? Is it A, inferior gluteal artery, B, inferior mesenteric artery, C, lateral sacral artery, D, obturator artery, or E, superior gluteal artery? And the correct answer is A, inferior gluteal artery. The inferior gluteal artery is a branch of the internal iliac artery that participates in the crucia anastomosis around the posterior hip. The anastomosis connects the inferior gluteal artery with the medial circumflex femoral artery, lateral circumflex femoral artery, and first perforating branch of the deep femoral artery. In chronic external iliac or proximal femoral arterial stenosis, gradual enlargement of these collateral vessels can partially maintain perfusion to the thigh. The key clue is collateral flow between the internal iliac system and the deep femoral system around the posterior hip. Answer choice B, inferior mesenteric artery, is incorrect. The inferior mesenteric artery supplies hindgut structures and participates in intestinal collateral circulation through the marginal artery. It does not connect the internal iliac artery to the deep femoral artery around the hip. Answer choice C, lateral sacral artery, is incorrect. The lateral sacral arteries arise from the internal iliac artery and supply the sacral canal, meninges, and posterior pelvic wall. Although they are internal iliac branches, they do not form the major collateral pathway to the deep femoral system. Answer choice D, obturator artery, is incorrect. The obturator artery is usually a branch of the internal iliac artery and enters the medial thigh through the obturator canal. It can have clinically important pelvic and thigh anastomoses, but it is not the principal internal iliac branch of the crucia anastomosis that connects to the deep femoral system around the posterior hip. Answer choice E, superior gluteal artery, is incorrect. The superior gluteal artery is an internal iliac branch that exits the pelvis superior to the piriformis and participates in the trochanteric anastomosis near the femoral head. It is more closely associated with collateral supply to the femoral head than with the crucia anastomosis connecting the internal iliac system to the deep femoral artery. Key learning point. The inferior gluteal artery contributes to the crucia anastomosis, which can provide collateral flow from the internal iliac system to the deep femoral system during chronic external iliac or proximal femoral artery stenosis.
Across the country, United Health Group is working with local partners to build healthier communities every day. That includes helping partners like the Good Acre provide 45,000 meals and lower A1C in the Twin Cities, and helping Hello Family doulas deliver 44% fewer underweight births in Spartanburg. Because building healthier communities starts by giving people access to the care and services they need to live healthier lives. Learn more at unitedhealthgroup.com/commitment.
Amazon Health AI presents Painful Thoughts.
Why did I search the internet for answers to my cold sore problem? Now I'm stuck down a rabbit hole filled with images of alarmingly graphic sores in various stages of ooze. I can clear my search history, but I can never unsee that.
Don't go down the rabbit hole. Amazon Health AI gets you the right care, fast. Healthcare just got less painful.
Question 3, Anatomy 28. A 58-year-old man is brought to the emergency department after vomiting a large amount of bright red blood. He has a history of alcohol-associated cirrhosis and has had progressive abdominal distension for several months. Temperature is 36.8 degrees Celsius or 92.8 degrees Fahrenheit. Blood pressure is 86/52. Pulse is 124 beats per minute, and respirations are 22 per minute. Physical examination shows scleral icterus, spider angiomas, ascites, and splenomegaly. Emergency upper endoscopy shows actively bleeding varices in the distal esophagus. Dilation of which of the following venous anastomoses most directly explains this finding? Is it A, left gastric vein and esophageal veins, B, paraumbilical veins and superficial epigastric veins, C, short gastric veins and left gastroepiploic vein, D, superior rectal vein and inferior rectal veins, or E, superior rectal vein and middle rectal veins? And the correct answer is A, left gastric vein and esophageal veins. This patient has portal hypertension due to cirrhosis, leading to dilation of portosystemic venous anastomosis. Distal esophageal varices arise when blood from the portal system is redirected through the left gastric vein into esophageal veins, which drain into the esophagus system and then the superior vena cava. Increased pressure in these thin-walled submucosal veins can cause life-threatening upper gastrointestinal bleeding. The location of bleeding in the distal esophagus identifies the left gastric esophageal venous anastomosis as the relevant pathway. Answer choice B, paraumbilical veins and superficial epigastric veins, is incorrect. This portosystemic anastomosis occurs near the umbilicus and can produce dilated abdominal wall veins known as caput medusa. It does not cause distal esophageal varices or hematemesis. Answer choice C, short gastric veins and left gastroepiploic vein is incorrect. These veins are part of the portal venous drainage of the stomach and spleen through the splenic vein. They do not form the clinically important portosystemic anastomosis responsible for distal esophageal varices. Answer choice D, superior rectal vein and inferior rectal veins is incorrect. This is a portosystemic anastomosis between the superior rectal vein, which drains through the portal system through the inferior mesenteric vein, and the inferior rectal veins, which drain to the internal pudendal and internal iliac veins. Dilation can contribute to anorectal varices, not distal esophageal varices. Answer choice E, superior rectal vein and middle rectal veins is incorrect. The superior rectal vein drains to the portal system through the inferior mesenteric vein, whereas the middle rectal veins drain to the internal iliac system. This anastomosis is located in the rectum and would not explain bleeding from varices in the distal esophagus. Key learning point. Distal esophageal varices result from portal hypertension causing dilation of the portosystemic anastomosis between the left gastric vein and esophageal veins draining to the azygous system. And that will conclude this episode of our USMLE Step 1 Questions podcast. I hope you enjoyed it and found the information useful. Please be sure to follow us at MedPrepToGo on LinkedIn, Facebook, Instagram, and YouTube to stay up to date with our content. You can learn more and read other Step 1 questions at MedPrepToGo.com. Happy studying!